Let me, after learning and hearing about the venous outflow issues, which are more common, I can tell you right in the starting, you may actually have a good, you may restore the inflow, but most of the problem comes from outflow, and you may have an erection, but it may not be sustained and useful. So let me just go through all you want to know about interventions for male erectile dysfunction, and I will be restricting my talk to arterial inflow revascularization. As the previous speaker has already told you about the problem of erectile dysfunction, I'll just give you a little figure. Over 200 million men suffer from erectile dysfunction in the United States alone, and 50% of the men above the age of 40, between 40 to 70 years, would have some degrees of erectile dysfunction. And it is not only an underreported disease, but it is also an undertreated disease. And I would actually, we have our urology friends here, and they would actually, sort of vet this suggestion that, most of them are undertreated. They do not come to us. And even if they tell them that there is a problem which can be treated, they sometimes don't want to do it for various social reasons. Now, if you look at the, the arterial supply to the penis, it will start, the problem can start right from the aortic bifurcation to the common iliac bifurcation, and then to the anterior branch of the internal iliac artery, and then in the in the pudendal artery, which is a very long artery, but usually it's in a dominant state. It's a sleeping artery, so you can't have a good caliber on an angiogram unless you properly vasculate this artery and then the penile artery. So we have divided theoretically this into many zones, but what is the most important is we are treating with the internal pudendal artery in this case, this talk. So again, whenever there is a lot of variation here, and it is very important that, there was only one trial which was done on the pudendal artery stenting, and it was sort of stopped in between, not because that the trial was not effective, but because it was supported by Medtronic, and Medtronic shifted its interest from here to the more structural invasive and aortic valve therapies. But in that trial, about 10% of the patients had stents put in the wrong artery, not in the internal pudendal artery, because of variation in the anatomy. Now, if you look at the causes of erectile dysfunction, it could be vascular, diabetes, medications, pelvic surgery, neurological cause, and endocrine causes, and of course, urological causes. Now, most of the cases in vascular causes are because of venous outflow problems, and about 10% would have problems with the inflow issues related right from the bifurcation to the artery. Now, there is a link between erectile dysfunction and cardiovascular disease, and this is because I'm a cardiologist. I sort of am also an endovascular specialist. I deal with a lot of these issues in my patients alone, but and there are many more coming in from the urology colleagues, from the endocrinologists, and from the imaging side. Up to 48% of patients of coronary artery disease would have erectile dysfunction, and 75% of men with coronary artery disease have problem achieving erection, and 67% of them would have problems maintaining it. And what is very important, and this is from a study published in the Circulation in 2004 by Rosen et al., that erectile dysfunction predates onset of symptomatic coronary artery disease and cardiovascular disease by about 3 years. So if you have patients of coronary artery disease, there is more than 50% chance you will have erectile dysfunction, and many of the cardiologists actually do not take that history, or they give beta blockers, and that also contributes or aggravates the erectile dysfunction in these patients. But when you ask the history, many of you would certainly elicit this history is there, and some people would not tell you unless you ask them. Secondly, if you have patients with risk factors and you elicit this history, you can actually predate symptomatic coronary artery disease about 3 to 5 years. Now, this is my first patient who had right stenosis in the mid left anterior descending artery, and also had stenosis in the pudendal artery. And this is not uncommon. This is our day-to-day practice when we see this happening nowadays. Many a times we do pudendal artery angiography along with coronary angiography or coronary stenting. Now, different type of therapies have been available. The previous speakers have actually alluded on that, so I'm not going to be talking about it. But what is very important is to understand when do we treat, do a pudendal artery stenting. It's not that every erectile dysfunction, if he has an inflow problem, that we go ahead and do the pudendal artery stenting. These patients have to qualify as complex ED. Now, complex ED means that when these patients fail PDE5 inhibitor oral therapy, only at the optimal doses, only then these patients are taken up for a possible inflow problem, and then they are evaluated. And the way they are evaluated is they first have a urological and endocrinological assessment and a psychological assessment. Then the risk factors are assessed. If the testosterone levels are in control, and if there is no neurological or endocrinological problem, we go and study their penile blood flow. And the penile blood flow is tested the way you have, the way it was been told in the previous lecture. You always do it by intracavernosal injection of atovaline. And if you have a peak systolic velocity in the penile artery less than 25 centimeter per second, and this means that there could be, and there is a very high chance that there could be an inflow problem. It doesn't mean that the problem would be in pudendal artery. It could be anywhere from the aortic bifurcation to common iliac bifurcation to internal iliac artery, the anterior branch, and the pudendal arteries. So we then, once you have this, then you selectively take these patients to the cath lab and then do a selective internal pudendal artery angiography. In our case, we always check these patients for coronaries also. Again, coming back to the same slide which I showed you earlier, we took on this project in Apollo Hospital, probably the first time in the country, and now we are the only two centers in the Asian region who are doing this pudendal artery stenting. One is in our hospital and the one is in Korea. Now, this is our first patient. Incidentally, he was a judge, but he came to know about our program, and he wanted to get it done. And when we did his angiography, we found that he had a high-grade LAD stenosis and a high-grade pudendal artery stenosis. And although he wasn't much symptomatic with his LAD stenosis, he was not even concerned about it. We stented the LAD first, and this patient was on Viagra therapy, 50 milligrams twice a day, and then took him on for a pudendal artery stenting. I'll just take you through the procedure. We go from the contralateral side, and then we take a mother and child approach and hook the anterior division of the internal iliac artery, and then we advance a microcatheter to do the angiography of the pudendal artery. We dilate these vessels, cross the lesion with 014 guide wire. Usually it's a whisper wire in our case. And then after that, we pre-dilate these lesions with a small coronary balloon. Usually it is a 2 millimeter or 2.5 millimeter balloon. The vessel sizes range from 2.5 to 3 millimeter in diameter. Now, this is the pre-dilatation, and then after pre-dilatation, we had the drug-eluting stent which was put in. So this is the result which we got, and this was our first case. And here the main problem was not, we were worried because it was a sitting judge, and we were worried about the perineal necrosis, penile necrosis, or pelvic complications. But subsequently, we increased our cases, and this is our published series, but now we have completed more than 60 cases in our series. The initial patients, we were doing more of plain old balloon angioplasties, and again, now with the presence of availability of drug-coated balloons, we have shifted back to drug-coated balloon angioplasty rather than putting in stents. Because initially we were doing it as a part of a trial, we were putting patients. We were putting drug-eluting stents from Medtronic, and this were 21 stents which we had put. The clinical success was in 31 out of 32 patients. And how we follow our patients, that's very important. The patients were followed up at different time intervals. They had a duplex ultrasound at 30 days and then 3 months. And at 6 months, we did an angiogram. And then every 12 months, we followed them with duplex ultrasonography. The patients were followed up for major adverse events and also for sexual dysfunction. And the sexual dysfunction was studied objectively on IIEF scoring, which is International Index of Erectile Function. And this is how we followed. And if you see the mean results, the pre-procedure penile velocity increased from 18 centimeter per second to 36 centimeter per second. This is our personal experience, which was published. 32 cases, the mean age was 58.2 years. 20 patients out of these 32 had coronary artery disease. There was no death, no perineal or penile gangrene. The technical success was 100%, although the clinical success was in 31 out of 32 patients. If you, whenever we were assessing sexual functions objectively, we followed the IIEF score, and the score had to improve by more than 4 points. So and what was very important is that there was a sustained improvement in the erectile functions. It was 68% at 3 months, 75% at 6 months, and 78% at 12 months. Quite similar to the venous results which have been shown in the previous lecture. But what is very important here are two things. One, that this is an independent and blinded observation, not by us, but by a different team. And also that the patients here were still receiving Viagra therapy. Not that the Viagra therapy was stopped, but these were patients who failed Viagra therapy, and this is the erectile function with Viagra therapy. So the penile velocity, which increased from 16 centimeter per second at baseline to 44 at 3 months, 50 at 6 months, and 58 centimeter per second at 12 months. Why this happens, we do not know, but probably it is because of an autoregulatory mechanism in the pudendal artery, but we really do not know. But the same has been the result in the Zen trial. There were other studies, other reports also on this procedure, but if you see, these studies they were not restricted to internal pudendal artery. They were restricted. They were on all the inflow problems, which could be internal pudendal or aortic or aortic levels. So, this is another study which has analyzed which patients are going to be actually being helped most, and this is also the result from the Zen trial. And what it says is that in Zen trial, there are 383 patients who were screened, 30 were treated, 93% were screening failure, and 56% of these patients had venous leaks. So although they had good inflow results, but still the outflow results were bad and the functional results were bad and suboptimal. The restenosis rate at 12 months is more than 40%. But what was seen here, in spite of the restenosis, the patient started, they still maintained their erectile function and the improvement in velocity. This was published by the PI of the Zen trial, Dr. Roger, and it was published in 2012. And the conclusions of Zen trial, which was published in 2012, was that it was the first in-man trial on stenting of internal pudendal artery stenosis in selected ED patients with suboptimal PDE5 inhibitor response. This appeared to be safe and effective, and there were no major adverse events, and there was improvement in the penile peak systolic velocities and IIEF scores. In 12 months follow-up in small, highly selected cohort that suggested internal pudendal artery stenting appeared to be safe and may be effective in improving erectile dysfunction. But the PI and both the companies supporting this actually shifted their interest to structural interventions, and that is why this trial was discontinued. And then the same trial, not with the name of Zen trial, but with the same protocol, was given to us, and we started this procedure, and then also we had another center from Korea. So now coming on to the roles of drug-coated balloons. That time we did not have drug-coated balloons. It is very intuitive that we do not want to leave a metal which sort of requires a dual antiplatelet for a long time. And also we do not want to leave a metal in a situation where the stent thrombosis is a risk forever and for life. And usually these patients are young to middle-aged. So that is why it was very intuitive to use drug-coated balloons, and now there are many in the market. We are studying two of them. Both one is a sirolimus drug-coated balloon, which is manufactured in India, and probably the only sirolimus-coated balloon technology available in the world. And the second one is we have 2-3 options available there, which are paclitaxel-coated balloons, and we are soon going to analyze our results of drug-coated balloon angioplasty versus drug-eluting stent angioplasty results. But intuitively, it looks that the drug-coated balloon may be better. So to conclude, stenting of the focal stenosis of internal pudendal artery is safe, feasible, and leads to a sustained improvement of erectile function in about 75% of cases. But these are very selective cases, not that all comers. However, still many cases are ineligible for pudendal artery stenting and have multifactorial etiologies. So these are the non-responders, and some of them have good post-procedure erections but suffer from premature ejaculation. So that's another issue, which is usually a psychological issue, and that needs to be handled as well. And larger studies are required to be able to accept it as an acceptable therapy or a standard of care for treating male erectile dysfunction. I'm going to be stopping here because a very good talk has already been done on the venous leak, and I'll leave it to the panel for discussion. Thank you so much.